Yes, I can see it.
Okay.
Yes.
And the full screen. Oh, now it's better. When last time we stopped, I think question 20. Let me see where I forgot. I think we did only twice. Hamad, do you remember Hamad Dahman?
I think 20, Samer.
Okay, so that's good.
Yes, Dr. 20.
خلينا نشوف إذا في حد جاي. Where is that here? طب اوكي خلاص بسام موجود هنا كمان كويس. So we can start. طب 20, let me see, 2015, 15. طب محمد, you want to start محمد?
Sure, Doctor. يلا بسم الله.
Sorry. Here you are, 20. You're right, 20. Here we are. Yeah. Correct. Okay.
Yeah.
Right, Sam, start, please.
A 56-year-old woman has a left upper extremity arteriovenous fistula with brachial artery inflow and complaints of severe hand pain during dialysis. Her axis is a year old and has been working well up until recently when her symptoms started. The flow rate in her axis is 1,200. The hand appears pale with an absent radial pulse. She undergo fistulogram. Okay, she undergo fistulogram figure 1 after the compression of the graft. Okay.
And one before, one after.
Yes. After the compression and before compression. طبعا before compression, you can see there is no outflow to the radial and ulnar and median artery.
Correct.
So after inflow, it's diseased artery, but there is improvement in the flow.
Correct.
Although the flow is not too high, it's 1,200, but this patient looks like she had already peripheral vascular disease on her upper extremity. So it can be considered as Steele syndrome. So we'll have to look for her, which is the best option.
Okay, remember last time we talked about high flow and low flow?
Yes.
Okay. This is almost like a normal flow, صح?
Yes, this is the normal flow, yeah.
The normal flow banding will not work, correct?
Yeah, we have to look for any other solution that improves the flow.
What surgery we have for C syndrome when we have a normal flow?
We can get a drill and trolley.
Right.
One of them it can work, yeah.
Or proximal, right?
Or proximal improvement, yeah.
Or distal, yeah. So you have proximal distal drill, you can do that. Okay, let's see what they said here. This is what is a. Okay, let's take first radial artery angioplasty. What do you think about that?
No, it will not improve much. The radial artery is diseased, but no significant improvement if you just balloon it. Because the problem with the dialysis mainly.
Because the steel is a problem.
Yeah, the steel is a huge problem in this patient. So angiographic assessment of inflow stenosis.
Okay.
Brachial artery looks good. Yani it does not look bad at all.
To say has a stenosis, but then the flow is 1,200. Usually when you have a stenosis, you see low flow, right? So this another thing is you have an inflow. First, they didn't mention the second thing, the flow is 1,200. So I don't think it's an inflow. Okay.
No.
What about ligation?
Axis ligation. The patient is not acutely, and it's not a acute event and no tissue loss. So it's mainly class A. During the dialysis, the pain comes. So there is a chance you can solve. You can.
You have to look at the question. What they say? What's the best option? Okay.
Yeah.
Because it's an option. Yes, you can like it. It's not wrong. You can like it.
Yeah.
Yes, I know it's not, but if you don't have to do drill procedure or anything, you can ligate it. But it's not the best option. You see, they want the best option. Because with the ligation, yes, you solve an issue, but you lost the axis. So it's not the best option. So the reason why it's wrong. But otherwise, you can do it, yes. Next one.
So distal revascularization and interval ligation procedure.
Which
This
they
is the drill. Yeah,
okay.
I think this is the best option among the others. And the last one is radial artery ligation. No,
Mhm.
this is very far.
Will not help.
Not solve anything. Yeah.
When this will help, you know, artery ligation.
Hmm?
When this will help, if you have a radial artery ligation, when that will help. If you have a distal, if you have a radiocephalic and get a steel,
Yes.
then yes, you can ligate it. Then you depend on the ulnar, you know.
Yeah, ulnar backflow, he can dialyze through it. Yeah, yeah.
I think yes, you decrease the steel because when you ligate the radial artery, which is the main inflow,
Mm.
or then you get the steel. So this is only for like distal radiocephalic fistula. So the best way really is a drill, distal revascularization internal ligation procedure.
Yes.
Did you do it before? You didn't do it. I'm sure you didn't do it before.
No, I just, yeah, I didn't do it. La. I
Yeah.
did one like it, but not the same.
I don't like it much, really.
2 weeks ago, I did the one with auxiliary artery to brachial bypass, and yeah.
I mean, it's good, but the only thing I don't like it because you have to ligate the brachial artery and do a vein bypass. So that now your hand flow depend on the vein bypass, you know?
Yeah.
Which is, I don't like to, you know, if something happened to this vein bypass, then you compromise the hand circulation because you ligate the brachial artery. But I mean, I didn't too many. I did maybe 3 or 4. I mean, they work very well, but and second thing, they have to be at least 10 centimeters from the anastomosis, the proximal. If you get it very close from the fistula, then you still get the steel. So it has to be at least 10 centimeters above the fistula. You know, this is important. You have to get the measurement and measure it at least 10 centimeters proximal to work, you know.
And always the vein conduit is the saphenous, right?
Yes. No, I mean, it may depend. I mean, if you have a good, yeah, I think must be saphenous because you don't want to compromise the arm veins if you want to use them later on, you know. Yeah, you get a saphenous vein and you do proximal, 10 centimeters above to the distal, and then you ligate the brachial artery just distal to the anastomosis. So this way the hand will get the flow first and then the fistula will get the second flow. But again, the most important this procedure to succeed is to get the 10 centimeter distant. Otherwise, you still get the steel, you know. It's very important. Ali, what do you do? Would you do a different procedure?
I didn't do any distal any drill really in my career. I will go to with C in my cases, and
Okay.
I didn't use any drill.
Yeah, I mean, it's not the best. It's not the bad options. I mean, sometimes you have to do it. I mean, to get the patient, you know. So it's not also a bad option. Look for other options, you know. But for the exam, they want you to answer D.
Sure.
All right. All right. Let's go to next one. Who's Bassam?
Yes, sir.
Yeah, 21.
Yeah. 65 years old woman who underwent left brachiobasilic arteriovenous fistula placement develops numbness in the thumb and index and middle fingers, as well as weakness with abduction and grip strength since the procedure. The most likely etiology is
If you can remember.
we are talking about a lady who underwent brachiobasilic fistula.
Okay. And she has numbness on the thumb, index, and middle. So the 3 fingers. You remember the nerve supply for the fingers?
Index, thumb. Yeah, this is the radial artery.
No, I'm talking about the vein, a nerve, because it's a nerve.
Yeah, radial nerve distribution.
No, radial is the other 2. This is a median vein, median nerve.
Median, yeah, okay.
You want to get a compartment.
Radial from the dorsum and median from the palmar area. So yeah, this is the median nerve distribution.
Yeah, so must be she got a median nerve, you know.
Median nerve neuroplex.
I think it's like most probably like anatomy, you know, question. What options they give you? Radial nerve. What about steel? Could be a steel?
No, it couldn't be a steel.
Why?
Steel will come with pain mainly, not numbness.
Only a pen. I mean,
Monomelic limb also with pain.
not only this one, but some, you see, steel, it come more than, it doesn't give you like specific nerve, come more all the nerves.
Yeah.
So
all
that you get like a medial ulnar all be damaged, not only like specific nerve. Specific nerve is more something local, you know, damage for some reason, maybe during surgery or something like that, but it's not. Steel syndrome will give you numbness in all the hand. It's not like nerve distribution. This is more nerve damage, you know.
Yes, you are right.
Median nerve, and it's not a very good question anyway. But let's go next to it, not waste our time here. Median nerve, yeah. Let's go 22. Ahmed, you want to take it, Ahmed?
Yes, please. There is much debate around performing basilic vein transposition as a one-stage or a two-stage procedure. Evidence shows that the only difference between the two procedures related to brachiobasilic fistula, a failure rate,
Okay.
infection, long-term primary patency or long-term secondary patency, or a Steele syndrome.
You see, they're talking about doing a basilic vein one stage or two stage, you know. Should you do it on one stage or two stage? There was a lot of controversy, which one is better. Most people, they said two stage is better. But really, when they did study, they found it's no different really between first and second stage in everything. In failure, infection, Steele syndrome, patency, it's no different really. The only difference they found, and this is something published recently, that after 2 years, they found the primary patency is better with a two stage. But 1 year is no different, you know. So the long-term primary patency. This is just, I mean, so the whole idea is that there's no difference between both, but the only thing, the primary patency, they found it's worse with the first stage and two stage, because I think the vein is still soft and not mature, so maybe have more compression, so you have more chance for failure, primary failure. But the secondary patency is no difference, you know. So now most people say you can choose whatever you like, which you feel comfortable, you know. But you can go either way, really, one or two stage now, because no different. Again, the only different, and the long, after 2 years, the primary patency was a bit better with a two stage. But if you do secondary patency, is no different. Ali, how will you do them? One stage or two stage? Or
we discussed this options before. I think my way is to do one stage really.
yeah.
They, as we said before, that they prefer two stages nowadays, but I do it one stage. I think the problem is to do a good tunnel and to pass your vein in a good tunnel without any torsion, without any problem. Then I think no problems will happen. If this, if you free your vein till the axillary point, and then you pass it in a good tunnel, I think no problem will happen, and the patency is very good. I do it one stage. Always, I do it one stage.
I agree with that, Ali. I do the same. One stage is better because the vein is still there. You can, you know, the only time I use a two stage if it's a vein is like a borderline. I'm not sure, like if it's like 2.5, you know, and the vein I'm not sure it's going to mature or not. Then I prefer to do stage. Then I'll do stage and then I'll watch it. If it mature, then I'll do a second stage. But if the vein for me from the beginning, I just go with the one stage.
And in adults, I think the vein is very good and have a good diameter. I think two stages will be preferable in infants and children where the vein is small.
Yeah.
So in these cases, I think you can do it in two stages. But in others, I think the vein is very good. The basilic vein, when you see it and you put some saline in it, you see that it goes up to 5, 6 millimeters, 8 millimeters like this. So I think in children, you have to make it in two stages, perhaps, but in adult, one stage, it's enough.
Yeah. So again, it's depending on how the vein looks. The second thing, guys, you have to look when you do a transposition that the junction of the basilic vein with the brachial vein, because sometimes they join in the middle of the arm, then you cannot do it, even if the vein is big, you know. So you have to be sure that the joint is all the way in the axilla, because if the joint in the middle of the arm, then you cannot mobilize it enough to do dialysis. So it's very important to look at that also. But again, I mean, if the vein is good, goes up one stage. If the vein is questionable, as Ali said, if young people, for some reason, small, then maybe you do 2 stages to be sure that the vein will mature. So you don't put the patient through big incision, then the fistula will fail. All right, this is good. All right, let's next to one. We go back to Hamad Ahman.
Yes, doctor.
All right.
The patient in whom hybrid catheter graft would be a reliable alternative for catheter-dependent patient is a 70-year-old man with recent tunnel line infection, an 80-year-old with severe heart failure, a 72-year-old with central venous stenosis, a 78 whose systolic blood pressure routinely drop below 100 millimercury during dialysis, a 59-year-old with mild central venous stenosis.
Okay, let's start one by one, Muhammad, okay?
Yeah, yeah.
What is hybrid? What we called it?
We called it hero graft.
Okay. So as you remember, we talk about it. The only reason we found the main reason to failure is what? Is
the low blood pressure.
So this D is not a good, because when patient pressure 100 is not good for hero graft, you know?
Yes.
We said that before, and it looks like they confirm it here. See, anything below 100, don't do it, because it's going to clot it, because a long graft, you know, so will not. So out this question, you know. Usually we do it when you have a central occlusion or stenosis, right?
Yeah.
Mainly occlusion, really, not stenosis. But if you have severe stenosis, then this would be a best option for this one.
Yeah.
If you have an infection, it's not a good, because you're putting a graft. So this is contraindication. So A is wrong, because if you have a long infection, you put a hero graft, you may get infection because of graft. So this is contraindicated. This is wrong. Severe heart failure, I don't think make a difference as any fistula. There's nothing specific about this one. So I don't think it's an alternative, you know.
Yeah, it's not alternative.
Intravenous, even C, I mean, it's intravenous stenosis, but you can argue, I say, you can balloon it and stent it, and you do. But this is what they usually do it for, intravenous stenosis. But in real life, you don't have to do it. You can dilate it, put a stent, and you do regular graft, right? But this is the best option for all. This is the last one. What is that? Mild intravenous stenosis.
And the patient is young.
And the patient is young.
Yeah.
Who was young? Did they say young? Patients whom hybrid. I mean, they talk in general, you know. Yeah. Mild central stenosis, no, you don't need a hybrid. Hybrid is only for chronic occlusion or severe stenosis, you know.
Yeah.
You can get through it, you know. So again, the whole idea.
The difference between C and D, doctor, is the age and they specify the central occlusion. They said mild or central. So I think C is more accurate.
Yeah. But the A is mild. The 5 minute central stenosis, you don't do hybrid, just balloon.
Yeah, you just balloon it, right.
Mild. Usually we do it in severe stenosis or occlusion, you know.
Yeah.
So but even in C, I think you can argue about it. I mean, this is the right answer, but you can argue in real life that you can balloon it, stent it, and go regular graft, you know. But in general, this is the time you want to consider hero graft is a condition you want to do it when you have a severe central occlusion, you know, or stenosis. Right. I think nothing about it. But the most important, the blood pressure, guys, the most important part, the low blood pressure. What is that here? They said contraindication for if you have a donor artery less than 3 millimeters, outflow vein that cannot be dilated to accommodate 19 fresh divide, allergy, or infection. It's contraindication to use a hybrid graft. Okay. This time you won't take this 24? Looks an easy question today.
Yalla, okay. 40 years old thin type 1 diabetic patient received a kidney pancreas transplant 3 years ago. The kidney is failing and it is likely the patient will need to restart dialysis in the near future. The patient has a complex access history with failed arteriovenous fistula on both arms and a non-superior vena cava occlusion. The access option that would be best for this patient.
All right.
Okay.
So it has
Yeah,
occlusion.
young patient with multiple failed accesses in both arms with central venous occlusion. So we'll think about lower limb.
Right. So let's see what options they give you for lower limb. Start one by one.
Saphenous vein transposition. Yeah, we can do it.
That you take it.
Yeah, we can do harvesting then loop graft. Femoral vein transposition. I don't think we need, because he will develop definitely lower limb swelling.
Okay.
Ankle arteriovenous fistula. I didn't see that before. I don't think it's a good option because we need good inflow and outflow. Femoral artery to great saphenous vein loop arteriovenous graft.
Okay.
Yeah. I don't know what's the difference between A and D.
What was the last one?
Okay, popliteal artery to femoral vein graft. It's not applicable because the position of the patient will be prone during the dialysis. It will be tough for the patient.
Yeah, and what they look at the questions, they want what the best for this patient, because all of them are really, you can do all of them, you know, but they want what is the best option. Let me see, how old is he? He's 40 years old. Most PBS option, yeah. What's the best option? They want the best option.
Yeah, the best option always is the native. So saphenous vein transposition is the best option. The next one is femoral artery to saphenous vein graft.
Unfortunately, no. I mean, yes, I mean, I will do saphenous vein transposition if I do it, you know, because I never did the femoral vein transpositions. But the problem is that, you know, femoral vein is big, and the patency, of course, much. The problem with the saphenous vein, and if you remember, we did a couple of them, you always end with a stenosis, you know, because it's not a big vein, you know, especially patient on dialysis, they see the vein is not huge, you know. So you end with multiple stenosis, especially at the venous. So femoral vein, yes, it's a huge vein. You transition, you know how they do it? They just cut it at the junction, superficial femoral vein with OPTL vein. They harvest it and they turn it under the skin and bring it back to the distal SFA, like a fem pop, you know.
Yeah.
The huge vein is very good. And the femoral vein, always you say like any femoral vein can cause a problem, but we do that all the time when you do like we have an infected aortic graft, you know. So femoral vein being used for as a conduit many times with moderate, you know, morbidity. So really, if you want the best options, is the femoral vein transpositions. Loop graft in the leg, we don't like to do a graft because of infections. You know, it's not the best option. But the only problem with the femoral vein transposition is the steel syndrome. It's a big vein. So you have to be very careful. You can't get the steel because femoral vein is huge. So if you do a vein transpositions, you have to make sure your anastomosis is small because you end with a steel. So again, I mean, for the exam, I think they want you to answer B. But in real life, most probably I would do saphenous vein transposition or graft. Ali, what do you think, Ali?
I think that this is 40 years old. He is diabetic type 1. So we have to take in consideration this point. This man will have, and he was in stage renal insufficiency. So he has calcified arteries. So I will go away from the D, no, so from E and C. I will not use these ankle and popliteal because the arteries are very calcified. So I will go to A. I think saphenous vein transposition is the best option for him in this patient type 1. Femoral artery to great saphenous vein. We can do a loop, yeah, but I think A is the best. In practice I use A.
Yeah, me I too. But I think let's see what they want.
But I will be away from the ankle and the popliteal artery because he's diabetic, so he has a problem in his artery 3.
Yeah. You see, the problem is that people who do this question, I don't think they're practical. They look only at the data and all the things, you know.
Yeah.
So
yeah.
Probably, yeah.
Femoral vein transposition is a procedure that very, very complex, and as you said, a huge vein. I don't know why they didn't use the saphenous veins, which more superficial and more easy.
Young patient has the lowest risk of infection. However, literature is sparing with regard to patency and outcome. Maybe harmful. Actually, found little data on Gessner's lupograph. Found that high complicant rate. As I'm saying, they're looking at the patency. Of course, patency would be better, but I mean, you have to look at
patency, of course. But I think Steele syndrome will be in these cases, and this procedure is very long and difficult. And I think I don't know. You have to go to more easier superficial veins, easier procedures. So this is the options that we use in these cases.
Yeah, look what they said here. You have to risk is complication table.
Ischemic complications, yeah.
Yeah, complication because it causes steel.
And the arteries, as you know, in these patients is very calcified. So
I don't know. I mean, this is what they want you to answer, but I think I will do the same. I'll do a saphenous vein transposition. All right. Again, guys, remember who put the question are people. It doesn't. They're not like, you know. They're not like, doesn't have to be correct, you know, but for the exams they're correct, but I mean, it's their opinion. All right, let's go to 25. Who is that? Ahmed?
A dialysis patient with long-standing brachiocephalic fistula is referred for a new onset of poor clearance with dialysis. An antegrade fistulogram is performed by accessing the cephalic vein, just cephalad to the anastomosis, proximal. An important step in this procedure is, okay, so fistulogram of brachiocephalic fistula.
He has a low flow. He has a low flow in the fistula, right? That was they said?
Yes. Yes, poor clearance.
Fistulogram. Okay, this is a very good question. I'll tell you why, but go ahead. So you do a fistulogram. What you need to do during fistulogram? They tell you, I give you all this option. First, measures the flow rate. Second,
angiography without flow venous compression.
Okay, let's go to third one.
Balloon assisted maturation.
Okay.
Primary stenting of an outflow venous stenosis.
Okay.
Or pressure gradient measurement.
Okay. I'll tell you why this is a good question, because I see that many times. You go and put your like, you know, your sheath for fistulogram just above the anastomosis, and you do a fistulogram and you look distal and you find some stenosis, you balloon it, you send it, you're done. What you're missing in this one, you didn't see the proximal, right? So this is a problem with this one. If you do like this one only, because remember the flow will go forward, that will not go backward because the flow go from the arterial to the venous. So if you just put catheters and inject and you treat whatever you see, you did not check your arterial stenosis, anastomosis, you measure something major. Maybe it's a problem in the arterial, you know?
Yes.
So always you should not miss these steps. So always remember, when you do this way, you have to close the fistula and inject. So when you inject, then you force the contrast to go backward, then you can see your arterial anastomosis. So what they want to tell you, always you have to check your arterial anastomosis. Also be sure it's fine, because sometimes you can get the problem from the arterial anastomosis, not the outflow. Okay?
Okay.
So this is the reason why they put this question. So what they want to tell you that if you do fistulogram, always check your arterial anastomosis. And the only way to do it by compressing the fistula and inject, so you get retrograde flow so you can see it, you know? Balloon-assisted maturation, this is a long-standing brachiocephalic, so it's not a new one, it's an old one. So you don't need balloon-assisted maturation, it's already mature. This is wrong. Primary standing outflow, we don't do primary standing. Always we balloon first. If it doesn't work, then we think about it. But most of the time, balloon itself will be enough, especially with the vein, not the graft, you know? And the pressure gradient measurement, I don't know what gradient you're talking about, it's no gradient. So again, the whole idea from this question, they want you always that don't forget to check your arterial anastomosis. This is a whole answer from message from this question. Okay?
Okay.
Yeah, don't just do a fistulogram. Yes.
Yeah. Sometimes they puncture an area, they can't see arterial and venous very clear. I think they puncture arterial itself, right? Or no?
Yes, some people they do that, but I don't like it, because if you inject the artery, if you put your catheter in the brachial artery, you know, it's a complication, everything. Yes.
Yeah.
But some people they do that, especially interventional radiology, when they do fistulogram, they cannulate the brachial artery.
Yes, yes, most of the time, yeah.
Yeah, but I don't like it, because if you get any bleeding, hematoma, problems, the brachial artery. But yes.
Yeah, where is the exact place for to puncture the cephalic vein, doctor? Like how many centimeters away from the anastomosis?
It doesn't matter. I mean, 1-2 centimeters is okay.
Okay.
And then you compress. If you see stenosis, then you have to put another catheter in retrograde, you know? So you compress it and you do an angiogram. If you see stenosis, then you have to put another catheters away from it in retrograde manner, and then you need to address it. So it'll be like 2 catheters, you know? So
Yeah.
to avoid that, they go from brachial, you know, to avoid that. Because if you go from brachial, you can fix them both at the same time. But again, I mean, just preference. I don't know, I can ask Ali what, but usually is the way I do it. I don't like brachial, you know, to go through the brachial. But I don't know if Ali does it differently. Ali, how you do it? Do you go through brachial?
agree with you. I agree with you.
Yeah.
Or you have to have long sheets, so I don't know if they arrive. Or you can go from radial artery. You can use it and you go back.
Yeah.
But I agree with you.
You go through the fistula, except the vein, because complication is less if you go through the vein.
Yeah.
Go through brachial artery. All right. Who's next now? Hamad, is you?
Yes, again, doctor.
Again and again. Well, going fast. 26. What time is now? Oh, that's good. Right, but go ahead.
The risk of low extremity ischemia increased after leg arteriovenous fistula placement in the presence of A, peripheral arterial disease, B, more proximal arterial inflow, C, use of prosthetic material, D, a size matched the femoral vein to superficial femoral artery, and E, venous outflow stenosis. I'm going with A, doctor, peripheral vascular disease.
Yeah, that's correct. That's why it's very important before you do a fistula to check the. See, our leg is different from the arm. The arm, even if you don't have a radial pulse, you can still go to a fistula because hand does not need much blood and tolerate ischemia very well. So many times patient has no radial pulse, and even though we do a fistula and or our graft, and they do fine, you know. So the hand is different because the muscle is not. You don't have many muscle. Legs is different. So if you don't have a distal pulses, don't do any access in the leg. You end with the major issues, you know. And legs doesn't do well with the ischemia. You see, you end with a toe gangrene infection, so it's a problem. So you be sure before you do any access in the leg, be sure it has no peripheral arterial disease. The second option, more proximal arterial inflow. No, it's up. The more you go proximal, the less steel. The more you go distal, it's more steel. So the reason why you need to put your anastomosis in the common femoral, not in the SFA. If you put an SFA, you get a steel. The reason why always you need to go more proximal to get less steel, like an arm. Prosthetic material, always prosthetic material, I don't think it make a difference if you do vein. I don't think this will increase, just increase your infection. Size match femoral vein to superficial femoral artery. I know what that mean, but maybe they mean that if you use a femoral vein, you get more ischemia, but it has to be larger than the artery to get an ischemia. And venous outflow stenosis is the opposite. It gives you more resistance or less ischemia. So really the best answer is A. So the whole message from this is that before you place anything in the leg, be sure you have a good flow to the legs. And most of it, you need a good pulses, Okay? So then, okay. Well, let's go next one, Bassam.
Yes.
27.
A 72-year-old catheter-dependent dialysis patient presents to the emergency room with pain and redness over the catheter side, as well as purulence coming from the exit side of the catheter. After removing the catheter, and initiating antibiotic therapy, the most appropriate timing of placement of a new permanent access is?
Yeah, this is a common issue, a common problem. We see it all the time. They call us infections. Should we do it right away or wait 24 or 48 hours with a negative culture, or say 2 hours? Or just whenever culture is negative, you can go?
Okay, usually we remove and we start antibiotics, and if he needs dialysis, we put temporary catheter. Then
Right.
whenever no signs of infection or blood pressure is negative, we can just put a new permanent one.
Correct. But the stage they give you B, C, D, E, O. They said negative pressure. So you know that you're looking for negative culture. But is it
immediately? No.
24, 48?
Culture is negative. If there is no signs of infection. You mean we have to choose date, time?
Because B, C, D are the same, all negative culture. But one of them immediately after negative culture, one after 24 hours, after 48 hours, and 2 hours. Because A is wrong, because you don't want to put it where you still have infection, correct?
Sure.
Give antibiotic until the negative culture. When you get the negative culture, should do it right away after negative culture, or wait 24, 48, or 2 hours? This is what they're asking you.
Probably we can choose 48.
Yeah, see, you're good in guessing. Yeah, so 48 hours. 48 hours after. Yeah, so 2 days. So after, so you give antibiotic until the culture become negative, then you wait 2 days. I think just to be sure that the thing's clear, or get like more antibiotic where the culture is negative, and then put your whatever, graft or whatever, but usually you want you to wait 48 hours after negative culture, okay? So information really is nothing like to think about it. Yeah, 48 hours, okay. There's nothing about it. It's just information, All right, Ahmed.
A 56-year-old right-handed man with history of a chronic kidney disease and the GFR of a 24. Currently not on dialysis, is referred for hemodialysis access evaluation, prophylaxis. His upper extremity pulses are normal on physical examination, and upper extremity vein mapping shown in the figure. Basilic and left cephalic on the right. The most appropriate management is, he is right-handed dominant.
So this is, they said basilic on the left. This is a basilic, and this is, what was the opposite to me? Basilic on the left and cephalic on the right. This is the right and this is the left. So this is cephalic and this is a basilic. Correct? Yeah. Okay. So what do you think is best option? Look at the vein here. This is
sizes are decent, but cephalic is a better option.
Right, because look, I mean, a forearm, or what kind of, we have a forearm, we have radiocephalic, brachiocephalic. What do you think?
We
Look at
can
the forearm. How big is the cephalic vein? It's 1.8,
mild 2.5.
2.1, right? So
Yeah,
cephalic is not good. Antecubital fossa 3, this is good.
it's good actually. Yeah, so distal upper arm is okay, but antecubital is better.
Oh, but antecubital, this is the beginning of the cephalic vein in the arm.
Yes.
So what you do in this one?
But this is the basilic column.
But this is left or basilic on the left?
This is the basilic column. The cephalic column is on the right.
Cephalic on the right.
This is I think this is, they said basilic on the left of mine or left here?
Yeah, the question.
Huh? This one or this?
And I think the viewer, right and left.
So this is basilic, this is a cephalic, and this basilic.
Yeah, should be.
I think.
Anyway, both the same. Look at that. The whole idea both the same. 2.3. The forearm is bad in both ways. 2.1, 2.3, 2.1. Okay, so both bad. If you look at the both are very good in the upper arm, right?
Yes.
So you have option between brachiocephalic or brachiobasilic. Which one you use for usually?
In one stage, brachiocephalic.
I always try with brachiocephalic, of course, because you just done and it's superficial. You don't have to mobilize it. So it's brachiobasilic, always the last option. So the best option for him would be brachiobasilic, brachiocephalic. Because forearm is very poor in both. Correct?
Yes, true.
So the best option brachiocephalic. Let me see what they said here.
But what comes first, doctor? The dominant hand or non-dominant hand?
The non-dominant, but this is not left and right arm. This is right and left.
The columns.
But if the situation, if I have like patient right-handed and they have good cephalic vein in the right hand, and in the left hand I have good basilic vein, no cephalic. What should I go first with?
Good questions. No, I still start with a non-dominant. I start with a non-dominant first. So I'll do a transverse basilic vein.
Basilic, yeah.
Yeah, Ali, what do you think, Ali? Let me ask Ali.
I lost the discussion because I had the phone call, so I lost the discussion. Sorry.
Yeah. What they are asking that if you have on the patient's left hand is right-handed and has a good right cephalic vein on the right, but the left had good basilic vein. So you do left.
No, I will go to the cephalic always. Really, I will go with the cephalic always.
Dominant arm.
Regardless, the arm. Yeah.
Yeah, I mean, you can. It's an option. So.
I will use always the superficial vein before I go to the other veins.
Okay, so if the left arm doesn't have
superficial and proximal, as much as possible.
Okay, so if the left hand has only basilic and the right has cephalic, and his right hand, you go to the right hand. Correct?
I will go with the right hand. Yeah.
I mean, it's a preference. No, I will go to the left, but it doesn't mean I'm right, you're wrong. I mean, it's just a preference. You can look at you look at the pulses, look at the radial. How old is he? Is he like an active? His typewriter hand is important for him. So you look at a lot of factors. It's nothing like white and black and white, you know.
Dr. Samer, believe me, patients will not give you his right hand because they are playing with the mobile during the 4 hours of dialysis. They cannot put it in the wallah. Most of them nowadays are refusing, not because they are afraid to write, because they want something to play with during dialysis time. So they don't want it to be punctured. Yeah.
They are right.
Well, let's see what that is. Let's go.
But when you know that these patients have a long life and you have to find some vein always, so you have to go with the most superficial and the proximal vein, then you go to other more complicated veins. So this is my point of view. These patients have many problems during their life. So when I use the basilic vein, I think I jump over many veins before. So I use always the cephalic radial on the radial artery, on the brachial, and then I will go to the basilic.
Okay.
Sure.
Well, Ahmed, let's say what the answer. So one by one.
First option was the creation of left brachiocephalic as soon as possible. This is a good choice.
Okay, next one.
Let's see the other one. Wait until initiation of hemodialysis, then creation, meaning temporary access, then the final. It wouldn't be good.
Okay.
Creation of left basilic forearm, this will need 2 stages. So
Basilic vein is good. Why should go to the, I mean, cephalic vein is good, so no need to go to basilic vein. So the reason why is wrong. Okay.
so wait until initiation of hemodialysis, then creation. So there will be also catheter against this. Then creation of left arteriovenous graft. No, use the autologous graft, then go for synthetic ones.
So I think is the best option for this patient, you know.
Yeah.
When we do it before dialysis, you know what the timing we do fistula graft for before dialysis? Because this one is not on dialysis, he's pre-dialysis, right? He's stage 4, I think, right? Ah, come on.
Pre-dialysis, yes.
Yeah, 20 filtration.
R24.
So he's on like stage 4.
Yes.
So when we have a stage 4, so it depends. Fistula, usually we do it before 6 months because you need some time for maturation, be sure things fine, you know. Graft, we do it within 6 weeks. So it's the difference between a graft and, because you don't want to put a graft ahead a lot of time, you know, because you get thrombosis problems. So if you want to, patient not dialysis, want to put a graft, either do it like only 2-3 weeks before, or I can do it at the time of dialysis, but I put, you know, I can put Flexine, the one you can it right away, so you don't have to end with the catheters, you know. But in general, graft put only a couple of weeks before, where the fistula need a couple of months before they get to dialysis. Okay.
Okay.
All right. So what question now? I got lost now. This is what? No, we didn't do that. This one. Okay. So let's go to the 29. Well, let's get somebody out from our group. I see Maitham. You want to do it, Maitham? Maybe she's not with us. Okay. We come back to you, Muhammad.
Maitham, he texted me he's in the emergency. He will join us as a listener only.
Okay.
So I'll take this one. A 47 years old type 1 diabetic woman with a stage 4 chronic kidney disease, not on dialysis, referred for permanent dialysis active evaluation. On physical examination, she had right and radial pulses are normal, while the left side radial and ulnar pulses are absent. Systolic pressure measurements are noted to be 15 millimercury lower on the left arm compared to the right side. She has no ischemic symptoms on the left arm or hand. The most appropriate assessment for suitability of the left upper extremity axis creation is. So
what does she have?
Maybe thoracic outlet syndrome.
Oh, and she has, you know, subclavian artery.
Yeah, subclavian artery.
Yeah, so we want to assess arterial flow because look, she has arterial flow because she has a gradient 15 millimeters, you know, no pulses. So most of it, she has subclavian occlusion or stenosis.
Yeah.
So they ask you what the best way to evaluate this one. They give you duplex, angio, segmental pressure, CT, or MRA.
And as a vascular surgeon, we usually use CT angio, but right. I think they mean arterial duplex here. They want us to start with something.
Why is that?
To measure the velocity, actually. And,
look at that here.
Not on dialysis yet, yeah. And she's stage 4, yeah.
You have to be careful. So that you don't want to push her to dialysis, you know. Otherwise, yes, angiogram is the best way. If she's already on dialysis, you know, or she's going for dialysis soon, but you know, we don't know. She's still don't want the one who push her for that. So yes, I mean, CT angiogram is the best, but here You cannot do it because of that. So this is out of question. CT angiogram, MRA, even MRA, it has a risk. Even with the renal insufficiency, it has a risk. You know that because you cannot do even MRA. So the only way left is to do a duplex. A segmental pressure doesn't give you an idea. It just gives you, drop of pressure, which we already know she has a drop pressure. So arterial duplex sound, show you where is the dump, where's the monophasic become, where biphasics, get an idea, and then you can go from there. Can you do CO2 angiogram, the upper extremity?
We didn't do it, but I don't know if it's applicable or not. It's applicable only for large arteries.
Usually CO2 allow only in the under the diaphragm, but one time I read you can do it for fistulogram, maybe because it's the venous, I'm not sure, but you can do it for fistulogram or for subclavian, but you have to be careful, but mainly should be below the knee, below the diaphragm. All right. Let's go to next one. So they need duplex ultrasound. Okay. 30. We go to you, Bassam.
Yes, sir.
A 52-year-old man has had multiple upper extremity autogenous accesses that have failed, as well as multiple failed grafts that have been complicated by infections requiring resection. Venography shows patent central veins. He is being considered for autogenous femoral vein transposition to the arm for new arteriovenous fistula creation. Which of the following is true about this procedure?
So they use a femoral vein. And I think they like femoral vein transposition. Again, I never did before, so but it looks as a good options. So they want to tell you if you use a femoral vein transpositions to the arm, femoral vein put in the arm, what the problem you can expecting. Let's start one by one.
Okay. Primary patency rates are poor. Should be better.
No, lax is good because femoral vein is big. You have a big vein, so this is really the best patency. So patency is very good.
Yeah, I said better, should be better. Patency should be better than the upper limb veins.
Correct.
Not poor. Perioperative complication rate is low. No, because harvesting the femoral vein is carrying high morbidity.
Correct.
Complication, yeah. Length of stay is short. No. Hand ischemia is a common complication. Maybe because it might lead to Steele syndrome.
That's correct. We said that's correct because we said femoral vein is huge.
Yeah.
So if you use it in the arm, you may end with a Steele syndrome because it's big. Yeah. Usually, either you need to taper it when you do it, or some people they put interposition like saphenous vein graft. They get a small like when you do a taper graft. Put the vein, a huge vein. I mean, if you put the art, like this is about sometimes some of them like 15 millimeters, 16 millimeters. If you put it on the artery, you get for sure you get a Steele syndrome. So you have to be very, very careful when you use this kind of vein. Yeah.
Okay. Obese and non-obese patients have similar complication rates. No, definitely the obese patient will have more
complications.
Yeah, more chance of bleeding, lymphatic leak,
or infection. Yes.
So I will choose D.
Yeah, I agree with that.
Okay.
Why? No, not B. The D.
D then ma'am.
Yeah, hand ischemia, correct. Yeah, I don't know. I don't know what this femoral vein transposition. I really never saw it, and I wish somebody did it before, can tell us more. But I have no experience with this one. But looks they like it here for some reason. Maybe in the state they use it. We have a couple minutes. Let's go get one more questions. Who's after you, Bassam? Ahmed?
Okay. A 65-year-old woman with end-stage renal disease who underwent a staged brachiobasilic arteriovenous fistula creation 3 months ago, developed worsening symptoms in the in the ipsilateral hand, including coolness, paresthesia, and weakness and pain. The pain worsens during dialysis session, stage 2 steel. The finding on duplex ultrasound that is most useful in management of steel syndrome is?
All right, so she has a Steele syndrome, and they want you to find how you make a useful in management. Tibet, my diagnosis in Tibet. Yes, the question.
Okay.
See, they want you what the most finding in duplex ultrasound help you in management. Okay.
Okay.
When you measure Steele syndrome, what the most important thing you want to know?
Flow rates.
Correct. The flow rate is the most important to know. Should I do like, banding or do other procedures? So when you talk about management, the most important, I want to know the flow rate. Is it high or low or normal, So let's talk about one by one, see what they said.
Reversal of a flow in the artery distal to the anastomosis.
Will not help because this is a Steele syndrome, we know that. So you see reverse flow. And the reverse flow itself is not a diagnosis of Steele. Even normal people, when you do fistula, you see reverse flow. So really, Steele syndrome is diagnosed by symptoms. It's not by just ultrasound. So even if you do the ultrasound and you see reverse flow and patient has no symptom, you cannot call it Steele syndrome. So reversal flow in the distal, it's sometimes you see it in the normal after AV fistula, even without Steele. So itself is not a diagnostic of Steele. Okay.
Okay.
Next one.
B, augmentation of arterial flow distal to the anastomosis with fistula compression. This is true.
This is normal. I mean, every fistula, if you cross it, you get augmentation distal. So this also is not a diagnosis of Steele, right?
Yes.
And if you compress it, you see augmentation of the flow distal because all of them, they steal blood distal. Yeah, all of them, the way they work, But Steele is different. Steele, that mean you have a symptoms, So just saying the reverse flow augmentation is not diagnosed with Steele, Okay.
Yeah. Elimination of flow reversal in the distal artery with fistula compression.
Yeah, it's normal also. When you compress it, you can see because the blood go normal. So all this, without symptom, they mean nothing. If you have a symptoms, yes, but without symptom, all the three could be normal after fistula. Okay.
Okay. So next is fistula flow rate measurements. Yeah, obviously.
What you want, because they want to manage the Steele. So the most important when I do ultrasound, I want them to tell me, not to tell me reverse flow. I know the reverse flow because I know she has a Steele. I know the flow will augment if you compress it. I want to know how much flow we have, so I can decide what procedure to do to fix it. Okay.
Yes.
Distal artery flow rate measurement. I don't think that will help me in management. I mean, how going to help? I mean, it doesn't matter, right? I mean, if it's high or low, it depends on what her symptoms. So the most important, again, when anybody talk about Steele, the first question you're going to ask him, how much the flow in the fistula, okay? So this should be clear. All right, guys, we finished 30. You want to keep going or that's enough for tonight? 31 question, fistula. I think maybe it's enough for you tonight. All right, so next time we'll start at 32. Any question about what we already talked? Well, this is a long session. I thought we'll be only 30 questions, so we have a lot of questions. But that's important because this is your bread and butter, practice, guys. This is, I think, very important session because that's going to deal with it every time when you do, when you go to your practice. This is the most common procedure we do. It's very important to understand the dynamic, how you do it, how you, becomes the right procedure for the right patient. All right, guys, thank you very much. And we'll see you hopefully next week.
See you.
Anything before we leave? You want to add anything, Ali?
No,
Okay.
no, thanks.
Thanks, everyone. Thank you.
Ciao.
Nice.